Good morning, class. So today we are going to touch bases on the medical history. It is not chapter 11. This is a different book, but the title is still the same, The Patient History and Documentation. So first off, what is the purpose of the medical history? So the purpose of it is just to give us a basis of treatment by the primary care provider or any provider really, on-call provider, a specialist, just anything, anyone that's providing care. It helps guide the treatment for the patient. It also recalls previous treatment, so you notice that you'll have um, medical histories for at least a year or longer if you look at the patient's chart. The reason being is they need to update that every year. And also reviews notes and laboratory results. So those are some of the purposes of a medical history. When they do their charting, it's important that it is in chronological order based on the most recent in the front and the most the most recent in the front, and the past ones is behind it. So that's what the purpose is. And also the laboratory results is in a different section. Uh, it's a lot of different sections when you're dealing with the medical history and the chart itself. It's also a base for statistical analysis, also for research, insurance data, and health department notices. One of the key things about health department notices is when you're dealing with uh, patients that has been diagnosed with a communicable disease. Communicable meaning that it is easily transmitted throughout the community. An example, tuberculosis, also gonorrhea, syphilis, some type of sexually transmitted infection. So the health department needs to keep track of those. Also, health history and chart notes are a legal document of patient treatment. With that being said, do not delete or do not exclude what you've done in the patient's chart. Therefore, my thing is, if it is not written in the chart, then it wasn't done. Say that the doctor was sued for malpractice and you didn't document the event in question, the doctor doesn't have a leg to stand on. So that's why it's a legal document. So when you prepare your patient, you need to first make certain that the examination room is ready, that it is clean, that the paper was ripped off from the previous patient, that all the supplies are there. And also, before you even call that patient to the back, you need to make sure that the chart has been reviewed. You don't want to just go out there blindly. Make sure that you look at the most recent 2 or 3 events, or 2 or 3 dates that the patient was there, so you could assess what you need to ask for and the purpose for their visit. most of the time it's for Most of the time it's for a follow-up, but then you never know. So preparing for the patient, the first thing is to look at their history and make sure that everything is in place. If their names are hard to mispronounce, ask someone. Please ask someone before you go up there into go out to the reception area. Also, you bring them from the reception area to where the interview would take place. Sometimes it'll be a little triage area. Sometimes it's actually in the room. Uh, so just wherever, make sure you speak clearly and plainly to the patient, and make sure that they are able to hear and understand you. And also determine if assistance is necessary. You could automatically know when assistance is necessary for a patient. It don't take long for people to know when someone needs assistance. Also, when preparing for the patient, you need to make sure that you have a friendly greeting, um, appreciated and helpful. Don't go out there just looking like Miss Smith. Don't do that, because it doesn't build a good rapport and it's not friendly, and the patient will look at you like, no. So that's the whole basis of building a rapport. excuse me, the more professional you are, the more friendly you are, the better likelihood of you getting the full reasons why this patient is seeing the doctor. If the patient builds a wall in front of them, you won't get a lot of information. So the doctor will go in there blindly almost. So that's why we need to build a rapport. Also, as often as you can, use that patient's name. Also, making certain that you pronounce it correctly. So my last name is Quarles. So when people call me to the back, they usually say my first name, and then they'll ask, "How do you pronounce your last name?" I just really don't. I really, really hate to mispronounce your last name, and that's understandable. That's understandable. And also think globally. When you try to pronounce someone's name that's from a different nationality or different background, you have to deal with it differently. Okay, so make sure you introduce yourself and speak plainly. Don't speak fast if you're dealing with an older patient. Don't speak all loud and stuff because loudness doesn't help the patient hear. It's your tone of your voice that will help them hear. So if you have a deep tone in your voice, they're probably not going to hear it as well as someone that got a higher pitch voice. So you just got to adjust your tone of voice when dealing with the older population. And also, if you see this picture of the medical assistant and the patient, make sure that you sit the patient comfortably and sit face to face to begin the interview. Now, keep in mind of people's personal space. You don't want to get in their personal space whatsoever. So make sure that you get enough space to make them feel comfortable. Because if you're all in their face and you are in their bubble, they're not going to react like you want them to. And just keep in mind that every patient interview is cross-cultural. There are some people that will not speak to, or they don't want a male medical assistant, a male physician to help them. They probably want a female just because of their cross-cultural or their belief system. Um, some people prefer a male. Me personally, I don't care. As long as they give me the care that I need, it doesn't matter. But some people don't think like me, so just keep that in mind. It's cross-cultural. And also, health and illness is inseparable from social and cultural beliefs. It is inseparable. So you will see this a lot um, when you're dealing with a cross-cultural model. The patient and the provider's concerns are different in that the patient's chief concern is the actual illness. What is wrong with me, doctor? And the doctor's chief concern is what is going on? What can we diagnose? What is the disease or illness that can be? What is the disease itself? The patient's idea for treatment success is managing the illness. The provider's idea is controlling the problems. So it's different when you're dealing with a cross-cultural model. The patient thinks differently and the provider thinks differently. So when you're interviewing your patient, make sure you ask them open-ended questions. These are some examples. What do you think caused your problem? When do you think it started? Uh, was it a gradual type thing, or was it something that just came out of the blue? How long has it been? Describe the pain symptoms to me, things of that nature. And also respect the patient's perspective. The patient might be overwhelmed by the level of what's going on with them, but you could look at it and say, oh, it's just an ingrown toenail. It's nothing really serious. But the patient might think it is. So just respect that person's perspective in their treatment. Okay, so the information forms that we would need. One is the patient demographic form. And with that one, you will need their name and address, their home, work, or cell phone number, their date of birth, social security number. The only reason why they need your social is because in case they need to get you some procedures in, or if they are needing to uh, collect money from you if you don't give them their copays in a timely fashion. Those are some reasons why. Uh, Insurance information. Who are they going to bill this to for your own, uh, so you don't have to take responsibility for it? Emergency contact person. So in case you just fell out or something happened to you, who can we call? And also a release of information signature. So this is an example of a demographic form. It is on page 569 in my book, and that is an example of one. Okay, so the next form is a financial information form, and that one is on page 570 in my book. It just describes the financial policy of the practice, different strokes for different folks. Some providers have a more strict financial policy than others. Also, billing. Just know that they're going to, if you have insurance, they are going to bill that insurance policy first, and whatever monies is due, they are going to bill you. Insurance billing is just like what we said. Co-payments, most of the time co-payments are due right then when you sign in to be seen. Some people say, okay, well, we'll send you a bill. I have not seen that recently, but that doesn't mean that it's still not practiced. Also, finance charges. So say that you wrote a check and it was returned. That happened to me. So they're going to charge a finance charge to that. So I owe the balance of the visit plus X amount of dollars. My doctor's office, my specialist is $35. So it happens. So those are some of the details of the financial information form. Also, you will have a privacy form or a HIPAA form, and it just basically says that we will not disclose your information to anyone under any circumstance unless you give us that permission. And also to transport that information from one facility to another is done privately so that no one else can get to that information. Do a little research on HIPAA and just know that it's very serious. There has been a lot of hacks. There has been a lot of health information being compromised lately, the past few years. So just know that in the event of a HIPAA violation, there are civil penalties, monetary and or jail time. We don't want that. Okay. Release of information form. It is sent to former providers to obtain past medical records. An example, I see an ENT doctor for my chronic sinus infection. So I would go to my ENT doctor and I sign a release form to release all my information from that visit to my primary care doctor so that he would know what's going on. And that's just simple how it is. I have to give the office permission to send my information to another facility or to another person. In some cases, it can be used to allow sharing of information with family members. So if you would like to have your spouse or your friend or whoever get involved in your health care, then you will sign the release of information form saying it's okay for them to speak to that person or persons in regards to your care. Okay, so the medical history form itself, it is it's detailed. It presents health history, your present, what's going on with you now, why are you being seen, and also past, and also your past health history, that's personal and family. This light, Jesus. Okay. And also social history, including marital status, not so much sexual orientation unless it deals with some health-related issues like HIV and AIDS, and your occupation, your lifestyle, things of that nature. Military services and assignment dates. Reason why that's important because if you go out of seas and there's a lot of communicable diseases that you could bring back to the States, so they need to know. Body systems review and questionnaire. Medications. Make sure that you ask them for over-the-counter medications as well as prescription, because some over-the-counter medicines can contradict or have contraindications to a prescription. So you need to make sure you ask them about over-the-counter and prescription. And providers review of symptoms. That's also included in the medical form. Okay, so nowadays everything's supposed to be computerized. I think it was supposed to be until 2010, I believe, that it was supposed to be mandatory, 2010, 2012. But there's two types of computerized health systems. One is a patient-generated one, where the patient responds on a computer to questions and review information with the medical assistant for completeness. That's what my doctor does. It gives me this big old iPad looking thing and I answer questions. And if there's something that's not answered, the MA will come in and ask the questions so that it will be complete. And also there is a provider generated one. Well, that is when you take the patient up to the room, you get their vitals and get everything set up, and you ask the patient questions so that you could put it in the computer during the patient's interview. Some practices like to do the patient generated one because it seems to be a little quicker. Some people do provider generated where we complete the necessary information for that patient. Okay, so now it's time to take the patient from the reception area to the room so you can do the interview. Make sure you interact with that patient so you put that patient at ease. Build a good rapport with them. Make sure you guide the conversation because there's a lot of people now. Let's be real. There's a lot of people that is very talkative. They gab too much. So you have to guide that conversation. Make sure you keep that patient on track and you keep yourself on track because if you talk to that patient for a long period of time, that sets everything back because the doctor just wants to come in, spend that little 5-10 minutes seeing that patient, and they'll leave to go to the next one. Also, obtains the most information. Explain the terms or concepts. Remain professional and don't be embarrassed or uncomfortable by the answers that the patient gives you. You need to maintain an open mind and know that you have to respect the patient's responses and you have to maintain professionalism. Just because someone says something that you don't agree with doesn't mean that you should voice your opinion to the patient. It's not about you, it's the patient's perspective that you need to maintain and keep in mind. So interacting with the patient. Every time that patient comes in, you need to update the medical history as needed and also document the chief complaint. I like to do it in quotations, patient stated this. Or you could just do it as just saying chief complaint will be a follow-up or whatever you want to do. I like to chart it as if the patient told me this directly, which they will. So whatever is best for you. Keep it short and sweet. That's all it is, short and sweet. Okay. Also displaying cultural awareness. So what if the patient doesn't speak English? What if the patient has a severe learning disability? What if the patient is an elderly patient that is hearing impaired? Or what if they're just a kid or so in our age that's hearing impaired? How do we maintain professionalism and how can we obtain a good history with people of different backgrounds from us? That's where cultural awareness comes from. A lot of times they'll have someone to help them. Sometimes we do have interpreters, but that's for practices that is big, like at a hospital. If an interpreter is needed, complete business associate contract. That's because another person's coming in, and you want to make sure that person's information doesn't get disclosed to any and everyone, so they have to fill out a HIPAA form for that. Cultural barriers are addressed. So if there is a population where the husband has to be there to witness the wife get undressed for somebody, maybe the patient doesn't like to get undressed in front of someone they don't know. So you have to address those cultural barriers. Patient with mental disorders, you have to treat them with an awareness and with a professionalism too. Uh, Everyone is different, and you just can't treat one person different than from another person. And another thing is we need to listen and communicate with patients and the provider. Make sure you listen. It's a different thing if you hear it and you listen to it. So make sure you listen and understand and memorize and, pay attention to what is said with the patient and the provider. Also, make sure you be sensitive to patients' needs. I'm not saying being sensitive like your personality. Just know that some people may be frightened, they may be depressed. So be sensitive to those needs. Sometimes you might have to go an extra mile to help that patient that's fragile or hostile, to calm them down, or depressed to kind of build them up and say, it's okay. That's what we're here for. Be open to nonverbal and verbal communication. Just because they're speaking to you nicely and all that doesn't mean that their nonverbal is saying otherwise. So be sensitive to that. Maintain a professional boundary. I already spoke on that. Everyone has a bubble. I don't have one per se. If I invite you into my personal space, that's all good. My personal space is very small. And also know when touch is appropriate, because if you touch a patient and they don't want to be touched, that is grounds for an assault charge. And we don't want that on our record. It's real life. It does happen. I've seen it happen myself. So know when touch is appropriate. And don't be touching on everybody just because you're nice and you want to be friendly. That's the whole point of being sensitive to the patient's needs. So some people don't want to be hugged, some people don't want to be touched, some people don't want to shake your hand. So don't get up, just don't be upset when that happens. Also be patient and understanding with the patient. If the patient is upset, calm them down. It's as simple as that. But don't calm them down just to say calm down. That's not appropriate, because if you tell me to calm down, I'm not going to get calm. I'm going to get even more agitated and upset. Uncommunicative patients require special questioning techniques. Some people that is deaf, they might have someone there to read them sign language, or you could write stuff down for them. So they require special techniques when you're dealing with those type of patients. And also with patients that have a particular need, be sensitive to that need. It could be anything and everything. So just be sensitive to whatever need the patient might have. So this one is very important, because when you're dealing with patients, sometimes you have to ask them some questions that they don't prefer to answer, like their orientation, or their mental health status, or their drug use, anything of that. So when you approach sensitive topics, make sure that everything is private. It's just you and the patient, and there are no distractions. Ask those questions later in the stage of interview, because you want to build a rapport first. Don't go in there immediately and say how many sexual partners you have, because that's just going to throw the patient off. Use casual, direct eye contact, and don't stare at the patient. Do not stare at the patient. Make sure you pose questions in a matter-of-fact type tone, and also use normalized techniques when appropriate. So sometimes you have to flip the script and not be so professional. Just be yourself. How you talk to people outside of work. So that's what that means. Okay, communication across the lifespan. So from infant to child age, um, communication is with two people. It's with the baby and with the parent. The parent might say something, but if you look at the baby might be saying their nonverbal might be something different. Older children, they may do better without the parent present. That's how I was when I was 10, 11, and 12. I didn't want my mama to know what's going on with me um, in my development stages. I didn't want mama to know. So sometimes it's best that the parent will not be present. Teenagers that are old enough to make their own decision about when to be seen alone or with their parent. The older they get, the more independent they are. So the less likely that parent will be there with them. And the older population. So the older population, uh, they might have someone with them. They might have somebody with them to accompany them. So it's important to talk to them as well as to the patient. They may request an individual be present during that interview. Most of the time, it's their caregiver. And also, it's a good practice to use the HIPAA form signed by the patient that said it's okay to talk to this caregiver about what's going on with that patient. So the medical health history form, it is personal data from the demographic form. That is, when you see the form, it'll have the patient's chief complaint at the top. They have their name and the date of the date of the exam, and then it'll have chief complaint, present illness, and some other things involved in the form as well. Present illness, make sure you list all the medications included over the counter. Their allergies. It doesn't matter if it's medication or if it's non-medical, non-medication type allergies. Me personally, I am allergic to chocolate and strawberries. So I like to let the doctor know, even though there is hardly anything medical about being allergic to those two items, it's still good to know, for them to know. Also, list other providers and alternate therapy practitioners been seen. So you want to list everyone that the patient has been seeing. Also, medical history. Sometimes they'll ask you for the past 7 days, and they're gonna ask you something present, and they're gonna ask you something from the past. Have you had this in the past 7 days? And currently, what's going on with you? Also, family history. They want to know if genetics can come into play. So, does the family have a history of A, B, C, and D? And if so, is it mom, dad, sister, brother, auntie, baby daddy? It don't matter, whoever. Social and occupational history. Social history, do you drink? Do you smoke? Is it occasional? Is it social? Is it every day? Do you pop a whole case of beer in one day? Things of that nature. And then occupational history, what do you do for a living? If we put us being a medical assistant, we are more prone to getting some type of illness or infection or bacteria and nastiness. So occupational history is important as well. Review of symptoms by the physician or the provider. All of those is included in the medical health history. Okay, so next is how do we chart? So we chart in a couple of ways. One is called SOAP and SOAP-er. So when you think of SOAP, don't think of it as a bar soap. Think of it as subjective, objective assessment and plan. Subjective is of course, subjective data, the patient complaint in his or her own words. That's why I like to put patient states in quotation marks what their problem is. O is objective. What do you observe in the measurable findings? Measurable being their vital signs. Assessment. That's when the doctor comes in and they'll do a good diagnosis based on the subjective and objective factors, and then they'll plan their treatment. So the form be like subjective, I'm here for chest pains, been going on for 7 days, it's nonstop. Objective is to do an EKG. What do you observe? Do you observe them in physical pain? And also the measurable findings, EKG, vital signs, and also some lab work. They might need something to test how likely they are to have some type of heart disease or whatever. Assessment is the doctor comes in and he looks at every little piece of information that he has in front of him. And based off that information, he'll give you a plan of treatment. And the plan of treatment might be someone having chest pains, probably due because of their stress and their mental status. It could be because they're having a panic attack. So they would give them a plan of treatment, whatever medication, instructions, and when to return to them. That is SOAP. And then SOAPer adds education and response. We educate the patient on medications, might be on surgery, procedures, and stuff like that. We educate the patient as well as the doctor. We just reinforce what the doctor says. And we like to chart the response of the patient to the education. So if the patient claimed they understood, that's what we chart, patient understood, and go on about your business. The next one is CHEDA, not the chief, but it's an acronym. CHEDA is Chief Complaint History Examination, details of the problem, drugs, assessment, and return visit if necessary. So it's a little bit more detailed than the previous. It's a little bit more detailed. So just know the difference. SOAP, SOAPer, and CHEDA. I'll already touch bases with the chief complaint. What is the patient being seen for? If they say a lot of things, give the 3 most important things that patient is being seen for today, and have the patient make another appointment at a later time. The doctor has 100 patients to see, and he don't want to spend the whole hour to touch bases on every little thing that the patient said, because if we wrote it down, the doctor has to touch bases with that particular thing that we wrote down. So if we wrote down everything, the doctor gonna spend a long time on that patient. Make sure it's short and sweet, and the subjective complaint is known by patient but cannot be seen or measured by the provider. That's the whole point of it being subjective. We don't know what's going on, the patient does. And I already touched bases on this one as well. So where is it? How bad is it? How long is this going on? Do you have problems with other body parts? What makes it worse? What makes it better? And of course, how long has it been? Okay, history of present illness. So when you see CC on a test, on these slides, or anything like that, just know CC means chief complaint. This is part of the medical abbreviations that was supposed to have been taught in medical terminology. If it does, great. If not, then we'll have to just I had to give you a worksheet on that because it's more memorization. So history of present illness, that's when the chief complaint is expanded to give more information and detail. It allows the patient to describe the history in their own words. The chief complaint characteristics are very helpful. It's very helpful because it outlines what's going on with the patient. Family history, because a lot of problems with the patient can be hereditary. Also, it's often based on a prior health problem. Also, the medication and allergies are reviewed. And just like I said, in the whole time, make sure you list all medications, including over-the-counter medication. This kind of repetitious, but it's ideal to know what is going on because it is a memorization thing. And make sure that you fill out all the necessary paperwork in the computer, on paper, whatever you need in order for the doctor to know what exactly he needs to be in there for. I already talked about the medical history. They need to know everything. What all health problems, major illnesses, have you been hospitalized in the past, whatever surgeries you might have had, update immunizations for adults, allergies and medications. Make sure you update that. The book says at least annually, but I like to update it every time the patient's being seen. They might have been seen last week, but it's still good to say that you updated everything and everything is up to date. Family history, I already talked about that. Social history, already talked about that. Just their occupation, hobbies, sexual habits, spouse and personal status, their recreational use. Do they do recreational activities, use alcohol, tobacco, or other chemical substances? Some other things that I didn't touch on is their lifestyle and behaviors that could put the patient at risk. Some of it being their drug use, some of it being that they might share needles with someone and that could put them at risk. Also, lifestyles, us being a medical professional, we can go into a room and contract something because we're more prone to having illness. So the lifestyle could put the patient at risk. Um, Sometimes it can be necessary to ask about their home situation. Some things being uh, of neglect like symptoms such as poor hygiene, frequent infections, burns, smoke inhalation, malnutrition, and falls and bruises, especially in older adults and the pediatric population. Revere symptoms, already touched bases on that one. Is performed during the physical exam. Orderly and systematic checks on each body part elicits information essential to diagnosing of the problem. It also lists both the positive and negative findings, and it helps to determine the diagnosis. Okay, so patient records. Why is this so daggone important? Well, one is because it's a confidential information. It is the foundation for planning patient care. It's also a basis of communication among caregivers. It gives us a statistical analysis when you're dealing with research. It is a legal document. That's why it's important. It is a legal document. If it's not documented, it wasn't done. Just think of it as it may sound simple, but it's not. It is so not simple. HIPAA compliance forms, paper record storage in computer server areas. Make sure we're in compliance with that, as well as fax machines and workstations. We just don't want any information that's out and about so that other people can see what's going on. And it's because of a need to know. I don't need to know what's going on with this person because that person is not my patient. I don't even know this person, so to speak. So make sure that you have the fax machines cleared of anything and the workstation. If you were to have to leave that workstation, hit Control Alt Delete and lock it because no one needs to see what's going on with that person. I already talked about that, the contents of medical records. This is just repetitious. Continuity of care record, that's dealing mainly with the older population, developed by a number of medical groups, and it makes it easier and more efficient to transport patient medical information between providers. Also improves continuity of care and reduces errors. So with the continuity of care record, or CCR, it deals with the same thing as a medical record: patient and provider information, insurance data, the patient's general health status, recent care that was given, recommendations for future care, and reason for transfer or referral. Um, that's just plain and simple. And when you're dealing with the older population, just know that it likely includes advanced directives, a living will, things of that nature. It's completed by providers, nurses, MAs, and ancillary personnel. Um, Anyone can fill out an advance directive. You just have to have a witness to sign it. Can include outpatient, community-based, and inpatient services, and it can be transferred among providers electronically. Okay, so there are a couple of methods for charting. One is source-oriented medical record, or SOMR. It deals with a chronological set of notes for each visit. We use this more often. It may be typed by a medical transcriptionist from the provider's dictation. You notice when they have their little thing and they say patient space, this is going on with them space, and all this other stuff. That's them doing their dictation. And the other one is problem-oriented medical records, so POMR, POMR. It's a database with the medical history, results from labs, physical exam. That's the core of the record. And then a problem list that is individually identified with assigned numbers. We don't deal with problem-oriented medical records a lot, but just know that it is two types. It's the source-oriented one and then problem-oriented one. I was right. So electronic medical records was mandated by 2010. It was a requirement now to be electronic. Reason being, we could read it better. It has better methods of transport. It has better. It's just better to do it electronically. Better transport, better to save the data. Better to read, because a lot of doctors, I feel like they took a course on bad handwriting, so you can really know what's going on and what they're saying. Can be a part of the TPMS, and it's also available 24 hours, and it can be available to more than one person at a time. TPMS, that. Also know that storage is not a problem. Errors are less likely, like I said. If something were to be off a little bit, it'll flag it. And also standard rules for charting in both paper and EMR is pertinent. Rules of charting: make sure that it's accurate, clear, complete, timely, and entered properly. And just like I said, all this while, if it's not charted, it wasn't done. Okay, abbreviations. This should have been taught to y'all in medical terminology as well as dosage and a little bit of pharmacy. So we use abbreviations a lot when we're dealing with our charting. Some use it as shorthand. Some use to give exact meaning to finding. Keep abbreviations at a minimum. And only use the standard abbreviations. And I will hopefully give you a list of the common ones, but it's also on table 23-6 on page 586 in my book. And you will see these abbreviations again. You will. I also talked about this one, organization. Chart notes in a paper one must be kept in chronological order, most recent being first. It must be kept in an orderly fashion, and information needed easily gleaned by each member of the clinic staff. So if things is kept out of whack, it's going to be hard to find what you need, and it can be frustrating. So the best method, the best rule of thumb would be keep it in chronological order. And that's it. If y'all have any questions or concerns or anything of that nature, give me a text at 205-207-6716 or email me at gquarles@brownmackie.edu. I sure appreciate y'all, and y'all have a good rest of your day.